Start with the interesting part of the day. So Dr. Kilbourne, PhD, MPH, is Director of the VA Quality Enhancement Research Initiative, or QUERY. She's a professor of psychiatry here at U of M. Over 40 centers across the U.S., the mission of QUERY is to improve veteran health by accelerating the implementation of research findings into real-world practice. So this, for many of you, is actually a very relevant way to start the semester, because it does not do you any good to have these really great research ideas to improve things if nobody actually implements them. So her goal is to improve veteran health through implementation science, that is the use of strategies to help providers scale up and spread effective practices in real-world treatment settings. She is the recipient of several awards, including the PCASE, the Gerald Clerman Research Award from the Depression Bipolar Support Alliance, received her Bachelor's of Arts at the UC Berkeley with a double major in molecular biology and rhetoric, and her master's in epidemiology and a PhD in public policy from the University of California, Los Angeles, and we are delighted to have her here starting the year for us. Thank you, Dr. Kilbourne.
Thank you. I'm really excited to be here, and it's really a great opportunity to talk to the group. Let me know if I am going too fast or if I'm covering something. If you have questions, I always love to take questions throughout the talk as well. But I want to first kind of start out with a thought experiment, and mainly just think, how many of you have ever had to look up about a medical problem a family member of yours had? And how many of you first went to the internet? Good. The reason why I asked that is we would, in like sort of a perfect world, that all that information about what are the effective treatments for your family member's problem would be right there at your fingertips, or the doctor or the physician would have that information right at his or her fingertips. And unfortunately, we're not there yet. And I think in part because a lot of that knowledge doesn't really get translated into the real world. And especially for busy clinicians who may not have the time to read up on all the literature and so forth. So I'm going to talk a little bit about a couple things here in very broad strokes. And my job here is to really introduce some concepts of implementation science, what that is, and what a learning health system is, and aligning research with health system strategies, and then also thinking about study designs. And one of the papers I gave was really the end product of years of thinking and really a lot of time and effort it took to design that implementation study. Really, I think, came from a lot of the theories before us and a lot of the work before us by our colleagues and investigators about essentially building this new field of implementation science and what it's about. So I'm going to start with setting the stage and some definitions primarily. These are probably oversimplified for some of you, maybe. I try to get them down in one sentence just to get to the point. But I think of quality improvement and a lot of the things we do in hospitals to make sure that patient care is safe as the analysis of healthcare performance overall and systematic ways to improve it. Implementation research is more like that laser focus where you take something, a thing, an intervention, a treatment, and you study the best ways of ensuring that frontline providers implement that treatment effectively in routine care. Implementation strategy is the method by which you help frontline providers implement that effective treatment. And a learning health system is basically the concept by which you look at all sorts of interventions and things and making sure that the organization you work for is continuously improving its care by continuously looking at the data, finding gaps in quality, and implementing a new treatment or doing a quality improvement intervention and just reassessing over time. So that's essentially setting the stage at this point. But many times in research land, and especially in health services research and clinical research, we often have a conundrum. So that conundrum is that, I think about that Calvin and Hobbes comic where he's talking about throwing these snowballs would give me immediate and certain pleasure. Refraining from throwing the snowballs, would be, hope of getting rewarded later, that's great. And so we kind of think about all the work and how we're incentivized in universities to continue to just create new treatments. We're not incentivized to actually implement them. And oftentimes we just feel like we just sort of do the status quo. We just sort of keep on the treadmill of writing more grants to create new treatments, not necessarily create best ways of getting those effective treatments into routine practice. So why implementation? I think decades ago, one of my favorite movies growing up was Raiders of the Lost Ark, and Indiana Jones is out there getting the Ark and fighting all the bad guys, and all the basically where it all ends up is in some warehouse somewhere. And you think about if you're doing research and you work very hard and you basically have this great treatment and you have this wonderful way of implementing it, and then it just sort of gets shelved on the academic shelf or virtual shelf these days in terms of getting it published, and that's it. Because it takes 17 years to turn 14% of original research into the benefit of patient care. We're at that dismal point. This is again why we often have to dig on the internet to find that effective treatment for a family member, and because the physicians don't have the time nor the tools to find that information or even use all the effective treatments in front of them. And it's not their fault, they're just very busy. But too often we assume if we build it, they will come, that we create these treatments, but oftentimes these treatments and interventions, they could range from a pill, but they can also be a diabetes education program. They can also be treatments that involve depression symptom management. So they can be sorts of things that may not necessarily be a single dose of a pill. They often encompass treatments or interventions that we try to implement, often encompass types of interventions that you need more than one type of provider, like a diabetes nutritionist or a physical activity expert or someone like that, in addition to your physician. So complex interventions that require provider training is really where we get stuck a lot in terms of implementation. We build them, they're elaborate, they're wonderful, but try to find a clinic outside of your academic medical center to hire all those physicians and all those providers, and they don't have the time, tools, or training to train their existing providers in that wonderful intervention you created. The need for top-down support is important. That if we're going to support implementation, we need leadership to say that this is an important area. This is just something I wanted to throw in there. This is the current thinking in my field. There was a National Academy of Medicine report that was published that really strongly suggests that we're studying the wrong things. So I went to school and did my PhD at UCLA, got a degree in PhD in health services research, and now they're saying I need to be more focused on the nuanced problems that many health systems engineers are dealing with. So they actually highlighted health systems engineering as the emerging area of healthcare. So you guys are in the right place. Yay. But at the same time, I think about like my husband, for example, who's an internist. He's a primary care doc, and many times I have these wonderful and elaborate ideas. Well, we'd implement this and implement that, and then he reminds me of a story about Christopher Robin, where here's Edward Bear coming downstairs now, bump, bump, bump on the back of his head. He knows the only way of coming downstairs is as far as he knows, but sometimes he feels that there really is another way if he can only stop bumping for a moment and think of it. And oftentimes I get back to, again, the busy clinician, the busy physician, and oftentimes they're so busy. How do physicians find out about the latest and greatest? Is that they go to professional associations and seminars and workshops, and maybe once in a blue moon they may get a journal article. How we researchers think we change the world is we publish. We publish journal articles, and we publish lots of them, and we figure that everyone's going to be reading them. Everyone, all the way down to basically, essentially, our neighbor will be reading our articles, and it actually doesn't really work that way. So why should we care about implementation research, and why is this an important area? Implementation research is the scientific study, again, of interventions to help providers do the right thing and implement these best practices. Intervention or treatment is only as good as how and whether, though, that it's actually adopted, that practitioners are trained to use it, that trained practitioners choose to use it, that eligible populations and patients benefit from it. And if you think about the clinical impact, there's a diminishing return over time if you factor in all these potential bottlenecks into the process. So overcoming a persistent research to practice gap is going to have to take efforts to convince existing providers to basically do the right thing and adopt these treatments and use them appropriately. But we're not aligning our research questions to address this problem. Many research studies do not deal with existing providers. They do not work with existing providers. We often hire our own interventionists to deliver the intervention, and then when the research dollars go away, then that's it. We often design interventions that are not designed with frontline providers in mind so that they're feasible. There's variation in organizational capacity across different settings. We often think about top-down strategies, like we pass a law and everyone's going to follow it, and we find that even with the Affordable Care Act, when that was passed, that the implementation of it really varied widely. And then we have effective implementation strategies are needed at all levels so that basically the frontline clinicians and practitioners can own that process. So essentially it has to be a partnership between a researcher and the end user of any treatment that you want them to use. And then it's an iterative and not a linear process in many respects. So this is a traditional translational research pipeline. You do not have to memorize this graph, but essentially it shows that there's an iterative process. You have your discovery, you validate that discovery, you basically do an efficacy trial in humans to make sure that it actually works, and then you go through this whole process. But basically it's very slow, and that's why it takes at least almost a couple of decades for any treatment to reach routine clinical care. In implementation research, though, we often deal with what goes on in between. So we think about what are the evidence-based interventions out there already and where we want to get to, which is essentially the improved health outcomes among patients. But that's sort of the usual way we think about it, like cause effect. But there's stuff in the middle that happens when we think about thinking about implementation. And it's usually the how do you actually get existing providers to use the treatment? Are they using it effectively? So we want to measure things like fidelity, and then we want to measure if providers are using this treatment, and then whether or not patients are actually receiving it in a clinical service setting or a community practice place. And then finally, we want to make those connections to see if the patients themselves actually have improved outcomes. And this is really the implementation pathway we often think about when we do this type of research. So implementation is also context dependent. We have in the beginning the idea that there is a provider and a consumer or a patient. There's that interaction. That's fundamentally the most important part of any clinical care, but that occurs in a context of the clinical service setting. Are you seeing a provider in a rural clinic or a University of Michigan? Then you think about the organization. Are you seeing that provider within, let's say, a rural sort of health, like loosely based network of healthcare clinics, or are you seeing basically a provider at a Kaiser? And then you have the community. Are you in like an urban or rural area? And then you think about the state and also nation. So you have these multiple layers of where things can possibly go wrong or right in terms of trying to get your effective treatment into the hands of frontline providers and have them incentivized to use it over time. And there are stakeholders at all levels that help with this process. So achieving the art of implementation science is really through the use of implementation strategies, which are highly specified systematic processes derived from implementation frameworks or theories that are used and tested at the clinic or practice level. It assumes that just provider training is insufficient, and basically it focuses on dealing with these multi-level barriers such as lack of time, lack of incentives, provider incentives to use the treatment, lack of support, lack of leadership support, and so forth. Like clinical interventions, if you think about clinical intervention where you're studying the treatment itself, you want to also protocolize implementation strategies. And this is what we've been doing in our program in Query. And I'll talk a little bit about the Query program in general, and then I'm going to dive into some of the specific types of studies and things that we've been working on in Query. Our job is to accelerate the adoption of evidence-based practices into routine care using these implementation strategies. We have 3 priority goals, and basically our focus is we fund VA investigators to co-lead implementation and evaluation initiatives with clinical operations partners. So we work hand in hand with, let's say, the system leadership, much like you would work with the University of Michigan hospital leadership. We want our researchers to be working there in tandem to solve problems. We fund over 40 centers around the US, as Amy mentioned earlier. I won't go into detail there. And these are some examples of some of the projects we fund. They often, again, are complex interventions. They may be team-based care where you have evidence-based behavioral health care, which involves a nurse, a social worker, and a psychiatrist working together to basically see the same cohort of patients over time to make sure that that cohort of patients is improving their health over time. It may be stepped care for opioid use disorder. So you may have an issue where a patient comes in and they have an opioid use disorder issue, and then they want to be able to provide them initially some medication-assisted treatment, and then counseling, and then additional support over time depending on their level of severity. So these are just, again, some brief examples of the types of interventions we implement. Oftentimes not sort of that simple, but sometimes more simple than maybe a lot of other things. We've had a number of national impacts in our query programs. I'll just sort of brag here for a bit. I think I have to really thank our investigators that are the ones who've implemented all these effective practices, but we've reached quite a few, and I think what we're proud of especially is that we've trained more frontline providers in these effective practices so that they continue to use them over time. So these are the kinds of implementation strategies our overall query program has deployed. We often have learned about these implementation strategies from other investigators doing research funded by NIH and then also funded by the VA. But we basically have sort of categorized them into 9 types of groups. But the ones I'd like to really talk about particularly are the ones sort of toward the right, which is the identify and preparing champions. When you work in a complex health system with lots of providers, you often will want to find that one provider who's the early adopter and who can maybe motivate other providers and convince them to use the intervention. They're really, again, focused on improving provider technical and strategic thinking skills. There's a soft skill about this. There's also the skills, the technical skills of making sure that that treatment is being integrated into clinical care, but also integrated into the minds of the other clinicians who are always busy and having to think about, okay, why do I need to take on this one more thing on my plate when I'm busy enough? So it's really, there's the technical skills and the soft skills come together to form some of the best implementation strategies that we've known about so far. The examples of the core implementation strategies are here. These are sort of the brand names. I won't go into detail with them, but I'll pick out one in particular called evidence-based quality improvement. And if you're conducting an implementation strategy study using evidence-based quality improvement, what that means is essentially there are regular meetings with leadership at the clinics to ensure that the treatment that you want to implement is a priority with them, and you align their clinical priorities with your priorities. You also train frontline providers in how to actually embed that clinical treatment into their day-to-day practice. And then you also select a few of those providers to be champions where they also work with other frontline providers to talk to them about, okay, here's how you can utilize this treatment over time. Let's do a huddle every week to see how many patients are getting this treatment, if they're improving, what we can do to actually deal with any unintended consequences, such as maybe clinic appointments being late and so forth. So there's really this interactive, multi-level way of doing things. Evidence-based QI has been around for years. It was developed by many of our VA investigators and was usually used to implement some of our more complex treatment interventions. This is a systematic review that Query had sponsored to look at the impact of implementation strategies to use in clinics what we call beyond early adopters. How many of you have heard about the Rogers Diffusion of Innovation model? Early adopters, early majority, sort of the, okay. So the idea of the sort of the diffusion of innovations is that any sort of innovation out there, doesn't have to be healthcare, follows this natural course where you always have the innovators, like the people who got MP3 like 25 years ago. The early adopters are the people who got maybe the first iPod. The sort of early majority waited until the technology got better and got something else like the iPhone, and then it goes on and on and on, and the laggards are still using cassette. So essentially you have this pattern, and it usually follows naturalistically in many things, where it kind of, essentially what you want to do is the point at which you want to get maybe a few people into getting a lot of people to adopt something is really is sort of that hinge between early adopter, early majority, and then you really start, once you figure you've convinced the early majority, that's really that point in which you can convince the later majority. The problem was most of our implementation strategies up until this review and up until a few years ago were only working with what I would call our best friends, our sweetheart clinics. These are the places where they just love you and they just want to do anything for you because you're a researcher. They're great. But we wanted to reach out and get later adopters to use the clinical treatment. So we did a systematic review of basically not just the literature, but real world experiences from Kaiser and from other places to say, you know, how do people actually get some of the folks who may be more skeptical to adopt a new treatment or practice? So we learned a lot, and this systematic review is basically a literature review, and again, and also interviews, a qualitative interview guide of many of the healthcare leaders and frontline providers. And essentially, we focused on the later adopters. What we found was that basically we had to understand why they were later adopters in the first place. It was basically getting away from calling them laggards, getting away, not calling them like they're stupid, you don't know what you're doing, but basically saying, you know, many sites are difficult. I think that's doesn't make them bad sites. And these are some insights generated from the researchers. I give you a whole bunch of N of 1s, meaning that we've had one experience here, one experience there, but not really tied together to basically come together with a plan. So one of the challenges and potential benefits was we wanted to think about what are implementation strategies that were helping these sites that were, again, a little bit sort of on the later adopter edge of things. Many times they said, I don't have any time, I'm busy. Sometimes they say, well, I'm doing something locally, I already am innovating, I have this other treatment that seems to be working fine. Or they'll often say something like, that's great, but my boss is telling me I have to reduce hospitalizations. Why do you want me to improve access? So trade-off time. So some of the ways in which we dealt with that was embracing their comments about low bandwidth, saying, okay, we know you're busy. How can, tell us how you're busy and tell us what we can do to adapt our intervention, our treatment, to make it so that we can maybe fit into a busy schedule of yours. And I'm oversimplifying this. This took months, by the way, so I'm just kind of getting to the point. Taking a long view, local innovations, that's great. Sometimes we'd say, we really like to learn from your local innovation, but if we learn from your local innovation, we'd love to maybe get some publicity on what you're doing. But if you don't mind, why don't we just give ours a try as well. Let's see, not to compete or anything, but just give us a try. Basically, kind of a trade-off between, we'll really showcase what your local innovation is if you can also maybe give us an opportunity to pilot test our innovation or our treatment in your clinic. And in terms of competing priorities, it's essentially needs alignment, maybe sometimes even going up the chain and advocating and saying, these providers really want to do this treatment, but I know you're really focused on reducing hospitalizations. Here's how this treatment might really be aligned with reducing hospitalizations. Again, very overgeneralizable, but nonetheless, really some key areas where we learned about how do you actually motivate providers at what we call later adopter sites. So these are some of the other examples of these. I won't go into too much, but some of the quotes was, after these implementation strategies were used, such as the ones I mentioned, we got quotes such as, they kind of stole from each other, which was great. We'll fight the battles for you. When you're a researcher and you basically are advocating for the frontline clinicians, that is a great way of building some great allies. And sometimes, allowing people to adapt. If they have a chance to adapt to intervention, then they have more ownership in that. So getting to effective implementation strategies, basically, we learned all this from literature reviews and from personal experience, but we've never really compared head-to-head what different implementation strategies will do in a setting to improve the uptake of a treatment. So a lot of things that our researchers have done in implementation science is use something called the hybrid effectiveness implementation design. Basically, it gets rid of this iterative and slow process of doing a really intensive, small effectiveness study of a treatment to maybe a larger study and so forth. What it does, it promotes the external validity, which means that essentially you're trying to see if you can get this treatment done in the real world. And it blends both implementation and effectiveness strategies and stages, and really as a way of comparing different implementation strategies like the ones I presented earlier. The types of hybrid designs really range from clinical effectiveness trials. These are types of trials where you basically compare whether or not treatment A works compared to usual care. It's sort of your typical clinical trial type design. A hybrid type 2 is when you basically say, okay, we're going to compare treatment A, but we're going to train providers to deliver treatment A compared to usual care. So you're basically combining the training of existing providers with the delivery of treatment A. And so it's a little muddled, but nonetheless it gets to where you need to go, which is essentially, can you show that treatment A works if you train providers in doing it? Hybrid type 3 is a little bit more wicked, because basically what you're saying is, we know that treatment A works, but we're going to compare different ways in which we motivate providers in using treatment A and see which one is most effective in getting more frontline providers to use treatment A with their patients. So essentially it's comparing, for example, maybe a learning collaborative where you talk to all the providers at once versus more individualized provider coaching or something like that. So there's different types of strategies, and I'll walk through these different types of designs. So a hybrid type 1 example, an effectiveness trial, we actually compared the effectiveness of a collaborative care model with usual care. And a collaborative care model was, imagine this being your diabetes self-management program. We used it in this case for depression. There was depression care management where you had a nurse or social worker follow up with the patient on a routine basis to make sure their symptoms were okay. And then they also provided self-management support. Usual care was wellness mailings. So in this example, we measured the impact of a collaborative care model compared to wellness mailings on the changes in what has been termed one of the common depression symptom scores called the PHQ-9 Patient Health Questionnaire, which basically looks like essentially, it's basically 9 items that basically assess depressive symptoms, and you follow it over time. We did get some, sort of a regression to the mean, but overall there was a difference if you use the collaborative care model. Now, hybrid type 2 example is similar to a hybrid type 1, except you're using existing providers and combining the training or the implementation strategy with the clinical intervention. So doctor office collaborative care was a pediatric version of our collaborative care model. It was care management, family support, which was self-management, and then we trained the providers and we consulted with them. So we did all this at once, and then usual care was standard primary care. Now, a weakness of this design, obviously, is that you cannot tease out the impacts of the pure care management or pure family support with provider training. But oftentimes, these study designs are used to actually kickstart implementation into communities where you may not have enough time and money to do a full-blown trial. You want to at least try out what these implementation strategies are. And at this point, this was done several years ago, we were just trying out this new training program and consultation program to see if it actually worked. So in essence, it's almost piloting the implementation strategy, but you then are able to write this to NIH and get it funded because you're basically powering your study on the clinical outcomes at the patient level. It's just sort of a trick there. So again, we found that the collaborative care program with this added on provider support had better, the patients or the kids had better outcomes compared to usual care. So hybrid type 3 example, what we did here was, I think, this is really the progenitor to the study that we circulated in the ASIC trial, was really to understand, okay, we have to roll out this intervention that's proven effective. It's a brief care management program to help essentially to help veterans with serious mental illness get back into care. So we used an adaptive implementation strategy design. The study was called Reengage. We knew that patients with serious mental illness, which are schizophrenia, bipolar disorder, major depressive disorder, often die at a younger age in the general population, often 20 to 30 years sometimes, and they're dying from unforeseen causes. We wanted to basically implement an effective brief outreach program to basically get them back into care and get them the treatment that they needed. And so we did a 2-arm clustered randomized trial where we essentially just rolled out something called Replicate Effective Programs, which is a training program and technical support. We rolled that out to all 158 VA facilities. And we found out that of those sites, 89 of them did not actually use the Reengage brief care management program. So we then took the sites that were not responding. Remember the Rogers Diffusion of Innovation. We kind of got rid of the early adopters. We said, you guys are doing great. We'll leave you alone for a while. We're going to take the later adopters. The 89 were the later adopters. And then we randomized them to something called facilitation, which was basically providing coaching and consultation to those frontline providers responsible for implementing this brief care management program. We found out that the facilitation was fairly cost effective. It was only about 7 hours per site for 6 months. So this is, again, the hybrid type 3 example. This is the REP model as it plays out. There's a pre-implementation phase where you prepare everyone to use this brief care management program. You identify your stakeholders, you package your intervention, you do this wonderful training, and even then people don't really stick to using this care management intervention because they're busy, and that's okay. Then you add facilitation. So we added facilitation that was our intervention, and our usual care was continue with the basically technical assistance that you would get from the REP program. So standard REP gave you a package, which was a manual of the brief care management program. You got the training, you got the technical assistance over time, which were essentially monthly calls, and we basically monitored how these providers were implementing re-engaged care management. Enhanced REP was all that, but it also was individualized one-on-one calls with that frontline provider. We basically figured out what their strengths were, We figured out what the barriers they're experiencing. We played to their strengths and try to match and find and strategize ways in which they can solve problems at the clinic to get the re-engage program implemented. We helped them to build coalitions at their site, how to basically sell and pitch this idea to their leaders and their fellow frontline providers, and also to make that business case to leadership, saying that care management programs can potentially save lives. We have the study, we found out it was effective. So what we found in this, and this is again a study design again, where again, everyone gets the re-engage program. Everyone gets the re-engage training. The providers are responsible for implementing re-engage, but the added facilitation was what we gave the sites that were not initially responding to that initial training program and so forth. We did find over time, and it's a little bit hard to read, it's a little small, but basically that the providers were using the re-engage program more. And we measured that by a number of times that they tried to contact those individual patients, and number of completed contacts, and number of times the patients got back into care. So we basically tried to measure, we couldn't measure patient outcomes, but what we were able to do is at least measure whether or not the patients were coming back into care. So another area that we started to explore was, getting back to this idea of the Rogers diffusion innovation model, was that you're always you don't sort of want to throw the kitchen sink down and use all these expensive implementation strategies at once, because some places are just going to adopt anything you do, and other places are going to need more help. So we designed what was one of the first sequential multiple assignment trials, basically to do something called precision implementation. That in many respects, implementation strategies, some of the ones that are more straightforward, you can probably use those at sites that are probably going to be your early adopters. Ones such as facilitation and coaching, where you need to spend a lot more time with the frontline providers and maybe get their leadership involved. You're going to need a lot more intensive implementation strategies, such as facilitation or that ongoing coaching, those phone calls you made to the providers. You just don't know, and oftentimes you don't really know at the beginning who's going to be the early adopter and who's not. It's really hard to predict sometimes. So SMART trials were really designed originally to do cancer trials like oncology and different types of oncology treatments, and we really sort of stole the idea and used them for implementation, because implementation is in many respects complex, and you have these issues about not all sites are going to respond to you, and some may not. The goal of a SMART trial is to basically inform the development of an adaptive implementation strategy, so in the future, which is almost like stepped care. In the future what to give sites first, what to give the non-responsive sites next, and so forth. So when you want to use SMART designs for implementation is when you don't know which implementation strategies should I start with, what should I do for sites that are non-responsive, and what should I do for sites that are responsive to first-line implementation? Should I leave them alone or give them something else? So this was the initial study that we did, was one of the first SMART designed adaptive implementation studies, where we basically wanted to look at the further implementation of a collaborative care model for mood disorders. What was the best way to implement a collaborative care model called Life Goals in community-based practices to improve patient mental health outcomes? So in terms of the background, the Life Goals program had basically been based on several clinical trials. It included self-management programs, like I discussed earlier, care management, a nurse or social worker following up with a patient routinely to make sure that they were okay, and if they flagged that clinician if something was wrong. And also practice guidelines for the clinician, particularly focused on physical health care management in patients with mental disorders, like cardiovascular risk factors, weight, and so forth. So we found that in several clinical trials that this collaborative care model for mental disorders would work compared to usual care, improving outcomes. Our setting in the ADEPT trial was several counties in Michigan and in Colorado. We wanted to pick some urban and rural counties and get as much diversity as we can. The implementation strategy options, again, similar to the ones in the re-engage study earlier. We started with REP, which was essentially replicating effective programs, a package, a training, and a technical assistance program. And then we offered external facilitation, which were essentially the virtual coaching calls we used in re-engage. But then we added something called the internal facilitation, which was essentially providing some nominal support to basically a clinical manager at that facility who had direct reporting line to leadership, but also knew how to get things done and was the go-to person, and basically supported them nominally to actually help with the implementation, but they were employees of that clinic. So essentially working to see if we can actually get their help in implementing this intervention over time. So together we thought the more intensive implementation strategies were the internal facilitator. Again, the external facilitator was off-site research team member. Basically, their role was to be an outside observer, a sort of third-party person and confidant and so forth. The internal facilitator was on-site, employed by that agency, first clinic. They really wanted to just, again, their job was to leverage and rapport build and basically make sure that the intervention was being incorporated into routine practice, inside expert, champion, and so forth. So this is how the study came about. So we first had a run-in phase. We started with the replicant effective programs model. We then essentially, for sites that did not respond to rep alone, we randomized them to rep plus external facilitation, and we added on external facilitation, or we added on a combination of external and internal facilitation after 6 months. And then after 12 months, for sites still not responding, if they were just getting external facilitation, we then randomized them to get added internal facilitation as well. And then we also continued the other sites with a combination of external and internal facilitation and monitored the outcomes at month 18. So a complicated trial, but you can see that each time there was a point of randomization, we needed to know if they were non-responding. The way we defined that was we essentially counted the number of patients they enrolled in the program and how many of those patients got at least 3 self-management visits from those frontline clinicians. So it was a very bimodal distribution. We basically had very few sites that were really gung-ho and did everything, and then we had a few sites that sort of tried this out, 1 or 2 patients, but we had a lot of zeros. Maybe a Poisson distribution is probably a more accurate way of describing it. As usual, you always have a lot of people that just don't do anything, which is fine. That makes it first. If we had everyone doing it, then we wouldn't have a study, so I guess it's a trade-off. Anyway, so what we found, though, is some interesting results. So we had a lot of variation, particularly across 2 states, Michigan and Colorado. They're kind of different to begin with. We didn't have much of a difference in rural versus urban, but we did have differences by state. Not surprising, we had 2 different external facilitators, 1 for each state, and they had different personalities, I suppose. But the effect, essentially, on the patient-level receipt of life goal sessions had no difference comparing the sites that got additional internal facilitation compared to sites that just got external facilitation only. So no difference statistically at all. We also found that, surprisingly, that there was a slight improvement in quality of life scores. So like higher score means better results. This is your quality of life for mental health condition. It was slightly higher for sites that only got external facilitation compared to those who got both. And the results is for the depression symptom scores, then we lowered them slightly better in the sites that only got external facilitation compared to external plus internal facilitation. So the more intensive intervention didn't really cut it. Because basically the cheaper way of doing things, the external facilitation was the better one, at least in the outcomes. So in spite of added expense and intensity, augmenting external facilitation with internal facilitation did not lead to better downstream patient outcomes compared to those offering external facilitation alone. So a couple of ways we thought about this, and actually what I didn't present was we broke it down by the sites that actually did nothing fared the best with internal facilitation, so keep that in mind. But in general, if you mesh them all together, external facilitation was more easily scalable. We felt that was also probably more appealing to the frontline clinicians. They like talking to someone who is perceived to be outside. They maybe could share a little bit more. They can be more of a confidant. The other issue, too, was the internal facilitators were chosen in part by the sites. They varied widely. Some of those sites took this to heart, and they did the study with us and really worked with us to find the best internal facilitator. Other sites, they were really wowed at what we were doing and then told their next manager that came into the office, literally. So you had really different ways in which and these sites were, again, community mental health programs, primary care clinics. These were fairly large clinics. So we felt that may have been another issue too, is we just had a lot of variation. The internal facilitators weren't really into it, which, not surprising, it happens a lot. So now we're basically at this point in our 3rd adaptive or smart implementation trial in the last few years, where we're basically taking this idea of this facilitation work to schools. So the adaptive school-based implementation of cognitive behavioral therapy, or ACET study, is basically focused on what is the best way of training school counselors as school professionals, these are your counselors from high school, teachers, and so forth, in the basics of cognitive behavioral therapy, which in turn they can deliver to their students. We know that 1 in 5 students are often affected by mood disorders, and only 20% receive any treatment at all. And evidence-based treatments such as cognitive behavioral therapy are effective, but the school professionals, the guidance counselors and so forth, and the school nurses are often not trained adequately in using cognitive behavioral therapy. So ACET will compare the effectiveness of a statewide school-level adaptive implementation intervention involving rep, provider, CBT coaching, which is what we used in previous trials where we coached providers in the mechanics of the how to use CBT, and facilitation, which was more the strategic thinking and being a confidant, like how do you actually get CBT integrated into your schools? So we basically, our main outcomes were frequency of CBT sessions delivered to students and then student mental health outcomes. This is a complicated design as it is, but kind of follows the same kind of pattern as a SMART, pointing out again that you start out with all the schools, and then the schools that are non-responsive, you randomize them to, again, at this point we randomize them to initially to rep plus coaching or rep only, and then we then randomize them to add on facilitation over time. So it's a little bit different at this point where we did the randomization sooner rather than later, then we followed them over time. So I'm finally going to maybe sort of talk a little bit about, I'm sort of shifting gears, and I want to sort of put this all together. We're in, about 4 days ago, I joined the Department of Learning and Health Sciences, which I think of as a big bucket where all these disciplines can come together and basically figure out how to improve care in health systems, like complicated health systems, like the University of Michigan or the VA for that matter. And part of my job is to basically use a lot of these study designs to compare different ways in which we can best prepare our providers to use these types of interventions. So we took the learning healthcare system knowledge to practice loop, and we applied it in query and basically came up with a roadmap that essentially we would want to teach frontline providers and the researchers on how to communicate the steps of implementation. Notice that it's not linear anymore because it's cyclical, because we often have to go 2 steps forward and 1 step back, especially if a site may have a crisis or you may have a new priority and so forth. But it really gets down to some key questions you ask at each phase. In a pre-implementation phase, you want to line up your stakeholders in the beginning. You want to figure out and come to a common part of what problem you're trying to solve, and essentially pick the best practices or the effective treatments. So problem-focused research is increasingly what we're trying to do in health services research and in implementation. In the implementation phase, it's using your arsenal of implementation strategies. Some of them may not work for all sites, and some of them may be the ones that are perfect for the sites that are really low performers, depending on the situation, a comprehensive review of the different implementation strategies, and benchmarking if you're doing it right or if you're doing it appropriately. And finally, sort of the sustainment phase is making that business case. If you've successfully implemented something, find out who can own the implementation over time so that in the end of the day, you can go to the next problem of solving the implementation problem, but you want to be able to train others in not only the treatment that you're trying to implement, but the implementation strategies as well. And these are just sort of words of wisdom we learned from in our different query programs about what works best and sort of how to get these things done. So I won't go too much into the roadmap components, but I will just kind of highlight how it came together. It was in part a literature review, in part based on the experiences of that systematic review I presented earlier, but 3 phases are supported with like some guidance on who to involve, what to do, and how to measure it. Essentially, it came down to it. And the idea was to be able to enable a roadmap for clinicians and frontline providers working with researchers to implement an implementation study like the SMART studies that I talked about earlier. This is a more complicated slide, but this is essentially all the components of it. The idea here is in the manual is that you can be able to click on each component and figure out, okay, what do I need to do in this stage, a checklist in terms of how to implement the intervention. So I finally want to end with a really fun exercise we did in applying this roadmap. In the VA, they have a national network of Innovators Networks, which are essentially centers that do user-centered design. These are frontline providers who get to work in a center, and they basically get to sort of design a tool or an intervention that will solve a problem that they have. Like maybe it's ordering of medications all the way down to, what kinds of self-management techniques can I use for patients with chronic conditions. The Diffusion of Excellence is another VA initiative that takes some of the best ideas from the Innovators Network and uses a contest in which they essentially get vetted, and the finalists get to present their idea in front of healthcare leaders and pitch it like that show Shark Tank. The idea there is to basically get that buy-in from leadership at the beginning so they also own that process of implementation with that frontline clinician, thus leading to hopefully more chances of sustaining that innovation, that effective intervention. And this was a great program that had been developed in the VA several years ago. The idea was to empower the frontline and get them to have some fun in creating something, minimize negative variation, and finding ways in which you can spread those best practices nationally and getting champions and leaders to bid as sharks would do, and then foster commitment to excellence. In the initiative, the timeline was essentially the finalists were selected, and this is actually usually hundreds of applications they would get, hundreds of ideas, innovations. And they make a pitch video, and then they use that pitch video and present in front of the sharks, who are the healthcare system CEOs and leaders around the country. And then they actually basically are the ones that are selected, or if a shark bids on your best practice, then you're able to get gold status and you get more support to actually help replicate that practice at a new site. So how this works is basically in 2018, they got over 500 promising practices. They had essentially 19 Shark Tank finalists. And then Shark Tank winners were matched to query implementation trainers. So we had query centers who volunteered to train these folks in the implementation roadmap. These were the types of implementation strategies that they were trained in. So essentially, getting back to the idea, we need more frontline providers implementing effective practices using implementation strategies. We wanted to train those frontline providers in the actual use of evidence-based implementation strategies, such as facilitation or such as the replicating effective programs. So this is one example. Dr. Judith Long is at Penn, and she had an effective intervention. And this IMPACT program, which was her effective intervention, was essentially training community health workers to work in the VA to work on basically helping our veterans, particularly ones who might have food insecurity or housing insecurity, and getting them placed in situations where it would be safer for them and more stable financially. So they worked a lot on social support. Most of our veterans are men, and they often live alone, and they often have some, essentially some social issues as well as maybe some income issues as well. So it's really a vulnerable population for many reasons because of comorbidities and so forth. So this was a health worker program that she created and implemented, shown in top journals that it also not only improved their outcomes, but it reduced hospitalizations. The hospital leaders picked up on that, they liked the idea. So essentially she applied to be in front of the Shark Tank. So she got selected as a finalist. She basically was selected, her program was selected as a winner, and then was matched to a query center and was matched to Lynette and Marina, who are her implementation strategy trainers, to get the IMPACT program disseminated at different sites. And they used a program called, an implementation strategy called Design for Dissemination Implementation, which really focuses heavily on actually allowing frontline providers deliberately to adapt the intervention to their local needs. So it really was not coming in and saying, hey, you're going to do this intervention. It's more like, we have this idea of helping veterans. This is sort of the general layout, but we need your help. Tell us how to adapt it. So some of the lessons learned is that you need bottom-up as well as top-down implementation strategies that you need to specify from the start. You need strategies that will deal with the leadership as well as deal with the needs of the frontline providers. You need to show what's in it for them, what's in it for me, the return on investment. Hard to engage sites are highly variable. They require tailored strategies and oftentimes may have a gem in them. You may learn something from those hard to engage, those later adopter sites. Just don't call them laggards. Providers lead from the middle often. Let them own the implementation process, let them own the adaptation. Keep in mind what your core elements of your clinical intervention are so they don't get too far away from it, but at least have them, adapt as much as you can. Demystify implementation science, which is why we're training people in the query implementation roadmap. This is not something that needs to stay in the ivory tower. It cannot stay in the ivory tower. It has to be in the real world. And we need to train more people in the art and the practice of implementation, how to actually implement things. And then essentially just my favorite quote about implementation science is, if you feel that the idea was his or hers, it's really a way of motivating folks to do the right thing. And I will stop there and take any questions. So thanks for your time.
All right, so number one, we have a little gift because I tend to forget when we get into all of the questions. So I'm going to give you your gift now, and thank you for a wonderful talk. And then I'm going to open it to Mark and Alex and anyone else who's brave enough to ask a question, because I need to find my glasses to start reading your questions. So anybody brave enough to get us started?
Yeah. First of all, fascinating, and thank you. Interesting challenge, especially, you caught our attention when you talked about the slow implementation. And it strikes me that the 17 years, if that was the number, is probably related to the life cycle of medical education.
That's
it
right,
takes that while to work that through. And I will profess that I have not studied the VA reimbursement system, so I don't know how payment mechanisms work. But to what degree does the payment mechanism, either for the organization itself or the provider compensation model, stand in the way of making any progress here? Or put another way, if you could tweak that, could you improve the implementation rate?
That's a really good question. Yeah, payment almost always gets in the way of anything. But even when, let's say Centers for Medicare and Medicaid Services will come up with a payment model, usually sometimes they'll bundle it and give you a sort of a lump sum for care management. It's sort of, you're still having to fight, it's still creating a situation for frontline providers to fight, well, how do we maximize that lump sum to make the most efficient care management process? So there's still organizational constraints that feed into the fact, even if you get paid for something. Right. And what has happened in behavioral health, which is fascinating, is how creative people have gotten to pay for a care manager, because psychiatrists are rare, primary care clinicians don't have time, and so they pay a nurse or a social worker to care manage. They get creative about which reimbursement codes to use. So part of that problem solving is the implementation strategy. But yeah, it's a really important point. But there still will be organizational barriers even with the finance being worked out. If that makes sense.
Thank you.
So the way you describe the practices of query, it sounds a lot like how the medical device industry does sales and support. And I'm wondering, because it's a different product and the incentives are different, does the practice of it end up being very different in certain ways, or is it largely the same kind of approach?
So when you say practice, you're talking about the clinical intervention, or
yeah, and supporting and selling it to people, right?
Yes, really good question. I think we're probably not as consistent as we could be in that, and the VA's made it a priority because we're kind of quasi single payer, that we can just sort of roll out these things and we have this national health system structure. We still have we have not perfected the ability to roll things out consistently. And my sense is it really varies widely. I think it takes a lot of time and money to get practices rolled out consistently, which means you have to do the same type of training and be able to spend that time helping individuals who might need some training in one area versus another. So what we're trying to do in implementation strategies is make the business case that, if you're a healthcare leader in a VA and you really want to improve PTSD care, just make some example up, and you know that brief psychotherapy works, but you need to train all those clinicians in brief psychotherapy, you need to basically pay for someone to not only train those individual practitioners, but to also ensure that they're using the psychotherapy the right way, like a facilitator. And we do these implementation trials to basically say a facilitator costs this much money. If you hired a full-time virtual facilitator, you would be able to cover like 30 sites. So we're not at that stage yet where we're able to monetize the implementation support it will take to make things roll out consistently. I think and it gets complicated because you get into the human factor, each site has its own variation of why they do things, and all the barriers, people come up with so many barriers why they don't want to do something, and having something imposed on them. It's always this psychology component to it. So you almost need that extra facilitator, that guide person who can help those sites really essentially do the right thing. But it's a challenge because we're still at kind of a toddler stage when it comes to figuring out which implementation strategies work best in a given situation. So I hope I answered your question. Yeah.
So thank you for the great talk and bringing science to something that's often very intimidating and abstract.
Yeah.
But so my question, if I think of quality improvement outside of healthcare, a lot of effective implementation strategies go to simplify the process. Like instead of trying to communicate it or standardize documentation things, like go back to the source and sort of make it the easiest path. And you mentioned the D4DI, I think, designed for dissemination and implementation. I'm wondering how many of the innovations that get brought to, say, your team look totally different from start to finish? Like, how much does your team focus on trying to make the process simpler versus just trying to communicate the existing idea?
That's really a good question. In the Replicate Effective Programs model, which, by the way, I probably should have talked more about it, the CDC invented that implementation strategy to rapidly translate HIV prevention interventions in the 90s when the epidemic was raging. They needed to get stuff out right away. So putting that aside, one of the things that they came up with at the CDC was we really need to simplify what the core elements are of the clinical intervention so that we know that those are the active ingredients that get the intervention's desired effect on people. Everything else is a menu option. So they use these analogies to try to allow people to embrace the complexity of having to adapt, but also to keep it simple. Another analogy the creator of REP came up with was baking chocolate chip cookies. The ingredients are the same, but you might bake them in a different type of oven, or you might have to, or like the other maybe more relevant one would be, well, that's relevant too, but group, like psychotherapy sessions, individual, group, on the phone, video. However, whatever medium you use to deliver psychotherapy, it's not just the delivery of psychotherapy, it's ensuring that psychotherapy is about having active discussion with that patient about their symptoms and feelings and finding coping strategies. That's the core element. The menu option is doing it by video, phone, by whatever. So that's kind of how we try to allow simplification just for people to wrap their heads around what the intervention is, but then allow them to adapt. Now, there has been some research out in Stanford looking at sort of natural history of how things get adapted over time and what that looks like. That's fascinating, and that's still that's Shannon Wiltsey Sturman. So it's WILTSEY-Sturman, STIRMAN. She's done a lot of work on natural adaptation. That makes sense. So, a good question. Yeah.
You just mentioned like audio and visual regarding audio and voice regarding phone calls for psychotherapy. When you do the training calls, are those just audio calls, or do they also use video, and are they individual or conference calls?
That's a great question. For the training in the treatment itself or the intervention, we try to do in person as much as we can, followed by virtual. We're finding even though we got a positive impact on all virtual facilitation, which is after they do the training, they know the intervention, we're just helping them use it better. We're finding that the literature has often said some face-to-face contact in general is really helpful if you can ideally do it at the beginning, just so you have that rapport. But we've done virtual facilitation 100%, and it seems to work okay too. So that's a good question.
So why don't we go ahead, stop now to make sure you all have time to find your partners and get going, and hopefully Dr. Kilbourne can stay for a few moments if some of you have just one-on-one questions that you're dying to ask, but let's go ahead and wrap up.
Okay, thank you.